The amazing evolution of therapies over the course of 15 years, utilizing initial TKI therapies going back to December of 2005 with the FDA approval of Nexivar, with a total of 13 new drugs over the course of the last 14 and a half years, has really been truly, and I have to quote Dr. Vogelsang, the embarrassment of riches. I think the fact that we are making significant progress is good, yet we are still able to take care of patients with subsequent progression, yet I think we're still trying to achieve the ultimate curability of the disease, something that we actually got a taste of when we used high-dose IL-2 in the late 90s and early 2000s. That being said, there are many studies that are being completed or recently completed that I think raise interest to. Presented at ASCO 2020 was a study of patients who had progression disease after immunotherapy, being an open label phase 2 clinical trial looking at axitinib and pembrolizumab, where there was an overall response rate of 55% of the patients. The median duration of response was approximately 12 months. Median progression-free survival of patients who achieved a response was close to 12 months. And I think then not only do we have this ability to utilize this combination of axitinib and pembrolizumab as a first-line therapy based upon the KEYNOTE-426 clinical trial, we now see a benefit of utilizing this agent as a second-line therapy after first-line immunotherapy. The Checkmate 9er clinical trial coming out, looking at the combination of Cabometyx, or cabozantinib, and nivolumab. Tony Schwery presented data on an oral HIF-2 alpha inhibitor, MK6482, and with an overall response rate of 24% as a second-line agent, whether you progressed after immunotherapy or TKI therapy. The disease control rate of 80% was quite impressive. And then we do also have the update on the KEYNOTE-426 clinical trial utilizing axitinib and pembrolizumab. Again, thinking about how to consider these agents not just for intermediate and poor risk, but also for good risk with a CR rate of approximately 11%. My message to community oncologists should be the same way we approach all of our patients. I think we have to, again, as we discussed earlier, consider risk stratification. I think by identifying the patients in the categories in which they may derive the best therapy and utilizing the NCCN guidelines, which again are very helpful. It's not the law, but it's definitely insightful as to how we should think our patients can be treated best. Thinking about sequences of therapy, allowing to believe that our patients will receive more than one line of therapy. And as I speak to other community oncologists, I think our patients are receiving 4 to 5 lines of systemic therapy, not just with benefit, but with great tolerability and nominal toxicity. As always, we should always think about clinical trials. And if you have the opportunity to enroll patients at your site or refer patients to a tertiary care unit that can actually have patients with clinical trials, either in first-line therapies or subsequent lines of therapies, phase 1 clinical trials, would be quite helpful as well. I think we have to think about patients. As always, I always tell my patients it's not about the cancer, it's about the patient that has the cancer. Thinking about their small factors that we don't always think about, their accessibility to the office, the financial toxicities. I think that data may drive us to believe what may be the best therapy, but if it's unaffordable, it may be very important for the patient to consider other therapies as well. I think that as a whole team, incorporating your patients in part of the discussions of options of therapy allows the patients to not only feel as if they're part of it, but it improves their communication to the physician and the physician staff, nurse navigators, nurse clinicians as well. I think the important care that the patient has, first-line therapy to any line of therapy, gives the patients the quality of life. And what our goal should be, their goals is not only improvement of survival, but quality of life as well.